This is It's Not In Your Head podcast with Dan and Jez. Dan is a doctor and Justine a pain coach. We've come together to find ways to manage complex chronic pain better for both patients and providers. Welcome to another episode of It's Not In Your Head with Justine Feidelson and Dr. Dan Bates. Hey, Dan.
Hello. Good to see you again.
We are very excited today to finally cover sensitization because Dan and I have been talking about sensitization. It feels for every day since we met pretty much. And it's the third component.
6 months.
Since August, since the EY conference. It's been a deep dive into trying to better tease out and understand and explain and tie the symptoms of central sensitization to better investigations and treatments. So it's essentially the third big component of pain after nociceptive and neuropathic pain, which we've covered in previous episodes. And central sensitization is the driver of nociplastic pain. So it's hard to treat that type of pain if you don't understand the pieces of what is driving it. So what we focused on is breaking apart central sensitization into its different components as much as we could. We're going to talk about peripheral sensitization itself in a separate episode, so just table that for now. And central sensitization is a lot of, at this point, what Dan sees in his patient population dealing with more complex chronic patients. It's almost all of who I see, not because I treat central sensitization on purpose, but because it is a big part of almost all patients with complex regional pain syndrome or other types of syndromes like that, like EDS. And so earlier in my career too, and I know for clinicians in general, when patients come to them and they're sensitized, as Dan said in a previous episode, it's confusing, right? It's a bunch of weird, vague, simple yet overwhelming symptoms a lot of times. And oftentimes as a patient, if you're in the pain sphere of things, you feel like sometimes it doesn't even apply to what you would be treating or dealing with in the pain setting. But it does, because the reason it's happening is because it is an amplification process of whatever underlying and coexisting conditions you do have that do need to be treated just like central sensitization. So Dan, you can probably speak to why, even from your perspective, it was more challenging to diagnose earlier and some of the tools that you've accumulated, before we met as well to make it a little bit easier, and then how you've improved upon that process now and how we've broken it down and are looking at it.
So look, as I said in a previous podcast, like the way your career starts is like, for me as a sports physician, I was seeing people, 2 days after they were injured. In that setting, most people don't have central sensitization, and they certainly don't have nociplastic pain. And as you start looking after people who have had pain for longer and longer periods of time, you start seeing patients that have more commonly got more complex pain presentations, and then they start having what's known as nociplastic pain. So as a quick review, there's 3 types of pain. There's pain that comes from body parts, pain that comes from nerves, and pain that is then an amplification of those other 2 planes, which is known as nociplastic pain. So nociplastic pain is driven by a process underlying, which is called central sensitization. And that process itself is probably a neuroinflammatory process of the central nervous system and components of the peripheral nervous system. And what happens is it neurologically amplifies sensation. It neurologically amplifies outputs so that you have more pain, more brain fog, more mood disturbance, and that becomes the whole how sensitization presents. And as Justine's already said, it's really confusing for the doctor, and it's really confusing for the patient, because as per the example previously, when a patient comes in and sees me, if they have central sensitization come in, the lights in my office have probably hurt their eyes. They've got a whole ton of pain. They haven't slept for months. They're fatigued. They've got brain fog, so they can't think, they can't remember, they can't concentrate. they're probably depressed and anxious, and they're certainly irritable most of the time. And then they may have dysautonomias. So they stand up and they get dizzy, and while they're sitting down, they feel like they need to go to the toilet all the time because their bladder's so hypersensitive. And of course, these patients are terrible historians, and pulling the pieces together is really, really, really confusing. And back in the day when I was seeing people after the weekend, they didn't have any of those symptoms. Makes it easy. And then you see people, as I said before, with osteoarthritis. Yes, they have some of this stuff, but not much of it. And then there's a subset of patients then after that are becoming increasingly complex. And for me, that group has been hypermobile EDS patients. And they come in with this component of body part pain, which is generally joint related stuff. And then they have a whole stack of central sensitization. And then after that, they get a bunch of immune disorders. And it's a progressive condition that we'll go into at a later point in time. But the central sensitization and all those symptoms are overwhelming and confusing. And so what we've done, as Justine's highlighted, is we've tried to categorize central sensitization into a group of symptoms that present regularly in most people. Now, I see this as exactly the same as every other organ, okay? So if you look at lungs have got a very small number of symptoms. So you get cough, you get wheeze, you get shortness of breath, you get pleural chest pain, and if you add in your trachea, you get stridor. That's kind of the end of respiratory symptoms. There's nothing else. However, the things that cause that are as like the list are as long as your arm. Okay. Similarly, when you get kidney dysfunction, what happens? So you don't wheeze so much, you get electrolyte disturbances, you get swollen ankles, you get high blood pressure, you get secondary like shortness of breath because you're retaining fluid. But at the end of the day, there's a very small number of renal or kidney symptoms. And so once again, the list is as long as your arm with regards to what causes those. But when they present, it's actually not that difficult. Similarly, with gastrointestinal symptoms, what do you get? You get nausea, vomiting, diarrhea, constipation, bloating.
General dissatisfaction.
Yeah, there's not that many symptoms outside of that when you're talking about, particularly your intestines. And so what causes all those? Once again, tons of stuff. Now, your central nervous system is essentially the same. And what does it present with? It presents with sensory hypersensitivity. It presents with sleep disturbance. It presents with fatigue, brain fog. So you can't think, can't concentrate, memory shot. It presents with mood disturbance, and it presents with dysautonomias. So that's dysfunction of the regulation of all your organs. And we'll sort of start to break each one of these down. You'll be able to see on the video a picture that basically just breaks these components out so you can see it. So it's neuropathic pain, nociceptive pain, which is body part pain, and then the components of central sensitization. And what it allows the clinician to do and what it allows you to do is if you can start going, hang on, I've got hypersensitivity to sound, smell, whatever. Right. I can then go on and manage that with this technique. Similarly,
now we have strategies that match. Yeah.
Yes. Now, the way we started looking at this is that there's a range of diseases that are essentially accepted as being caused by central sensitization. Oh, wiggle move for everyone, nearly. So those conditions include fibromyalgia, which is widespread pain, chronic fatigue syndrome, POTS, which is heart racing when you stand up for more than 3 minutes, probably post-concussion syndrome, because it's likely caused by a neuroinflammatory process. Another example is a good example, because everyone's living it, is post-COVID syndrome. And if you then go and you look at each one of those conditions, how do they present? They have their primary diagnostic criteria. POTS is a great example. You have to have a greater than 30 beats per minute rise in your heart rate with no decrease in your blood pressure after standing greater than 3 minutes. However, it's also associated with a group of other symptoms. So patients also get sensory hypersensitivity, they get brain fog, they get sleep disturbance, they get fatigue, they get other dysautonomias, and they get associated mood disturbance. And if you look through each one of those conditions, particularly chronic fatigue syndrome, post-COVID syndrome, and post-concussion syndrome, each one of them has got each one of those symptoms. And so what you can then start to do, and what we've started to do now, is categorize central sensitization. And so we're going to go through each one of the categories. And then at the end, what we'll do is we're going to give you a bit of an example of how we try and link our feature of central sensitization with an appropriate intervention strategy. So sensory hypersensitivity is hypersensitivity to nociception. And that will be one of two things. That'll be widespread. So that many times gets diagnosed as fibromyalgia, or it might be focal or in a region. And so that then fits into temporal mandibular joint pain, bladder pain syndrome, probably IBS, and a range of other regional pain syndromes. You get light sensitivity, you get sound sensitivity, you get smell hypersensitivity, which many people may get labeled with multiple chemical sensitivities in that setting.
Right.
People get sensitive to being touched. They just don't like it. They become heat intolerant. They get sensitivity to cold. Food intolerances may fit into this bucket as well. And then finally, people get balance issues, and that probably most commonly presents as falls. The next component is sleep disturbance. So sleep disturbance is a combination of inability to get to sleep, inability to stay asleep, and then waking early. Now, underneath that is a group of diseases such as obstructive sleep apnea, parasomnia, narcolepsy, that are specific sleep disorders that need to be then identified and gone on to treat.
Yeah, you're still treating a disease process along with sensitization, especially if it's an underlying cause.
Yes. Fatigue, you get lack of energy, cognitive fatigue, and physical fatigue. Within the realm of chronic fatigue syndrome, the primary symptom of chronic fatigue syndrome is called post-exertional malaise. And that is where you get exacerbation of your sensory hypersensitivity, sleep disturbance, fatigue, mood disturbance, and dysautonomias in response to exertion. And that response is disproportionate and prolonged, and it's not necessarily immediate. So it may come on 2 to 3 days later, it may be immediate, but it results in the exacerbation of all these symptoms of central nervous system dysfunction in response to exertion.
Right.
You then have brain fog. So brain fog or cognitive dysfunction is dysfunction of memory, concentration, and thinking. The best model for this is probably post-concussion syndrome. So post-concussion syndrome can be split into 5 major components. So it can be split into a migraine component, cognitive dysfunction, vestibular dysfunction, mood dysfunction, and then cervicogenic related post-concussion syndrome. And if you can identify those, you can then apply specific therapies to then treat them if that's part of the underlying driver. So then you've got mood dysfunction. So you've got anxiety and depression as some of your major pieces. A lot of that comes in that setting is then stress management. Like I think irritability is that presentation of I am just not, I don't have my normal resilience to manage the day-to-day annoyances that take place. And a lot of the things we can look at doing is then looking at someone, well, how do we improve your stress management skills to then decrease your irritability? And if someone's got clinical depression, well, that needs to be referred out and needs to be treated appropriately.
Yeah, in the mood psych bucket, a spectrum of...
Yeah. And so then the final component is then your dysautonomias. And your dysautonomias are orthostatic intolerance, which is when you stand up, you get lightheaded, you feel dizzy, you might get palpitations. As we mentioned before, if it's POTS, you just get an increase in heart rate, you don't get a change in blood pressure. And so they have that as quite straightforward, direct management strategies that are conservative that you can implement. There's then, first line and second line medications that you can work through. There's bladder dysfunction. So patients get issues with urinary frequency, urinary urgency, never feeling like they've emptied their bladder. This may be sensory, or it may be a regulatory piece where the system is just wound up. And so you're just going to the toilet all the time and just feel like you need to go all the time. And then you've got GIT symptoms. So GIT symptoms are abdominal pain associated with bloating, nausea, diarrhea, constipation. And a lot of time patients just get labeled with irritable bowel syndrome. And then finally, you've got hyperhidrosis, so sweating. And people get abnormal sweating. They do a small amount of activity and they find they break out in a massive amount of sweat. And
not even activity, but stress. Like just
yes. There's the
a lot of
emotional component. Like stress results in an excessive amount of emotional sweating. What happens in this setting is that if patients have moved through this process of seeing different doctors, what they'll end up coming to us with is they'll present with, you've got pain, and also I've been diagnosed with depression, anxiety, POTS, irritable bowel syndrome, interstitial cystitis, Raynaud's disease, multiple chemical sensitivities.
Yeah.
And so everyone's got the shopping list of conditions, which it doesn't make sense that someone would present with 20 different diseases. What they actually present with is one problem with multiple different presenting symptoms.
Right, in multiple dominant ways. Yes.
Yeah.
That's why Dan and I were like, there's absolutely no way that all of our patients have the same X amount of coexisting conditions in common. Not possible. So you can't all be accumulating different conditions. They have to be driven by a primary one that's then even getting misdiagnosed and labeled other things like Dan went through, just a few syndromes. There's many more very likely, which are actually just sensitization. And it's what system is it affecting? What I would also talk about too is that the whole point of this, right, is to be able to pull out central sensitization from the other disease processes that are happening. Because when you come in, the patient can't tell what bunch of their symptoms are because of EDS or driven by this. And so what this allows you to do is to categorize all the vague stuff and make sense of the, seemingly nonsensical or confusing, so that then you can separate out, okay, what's the actual pathology that this person is dealing with that then we can treat? And how are we treating the sensitization components that are manifesting in X, Y, and Z symptoms?
So, for example, I have a patient the other day that presented with right-sided neck pain. She's specifically been referred to me to get an epidural. And when speaking to her, we started to just pull out her primary symptoms. So she had disproportionate pain in response to something that probably wasn't going to respond to an epidural. It's not the point. But she had two main things that she presented with. So she had significant sleep disturbance. She had the associated fatigue, but it was a lesser issue for her. But she also had, when you probe, she had symptoms of orthostatic intolerance. So she would stand up, she would get dizzy and lightheaded, and find that she'd have to then sit down for a period of time. Okay. So over to Juz. So this patient presents with sleep intolerance. What's first line management that you would then go, okay, we're going to start to deal with this issue?
Yeah. Sleep's a great one because it's a very common, very impactful one. And the easiest way to start with it, I typically do, is wind down. You want to anchor somebody's sleep-wake cycle, and it's harder to get them out of bed in the morning at the same time if they haven't yet had a regular sort of intro into that. So anchor the sleep time, then anchor the wake time. And you're going to want to anchor that by helping somebody build a wind down routine, right? That helps them down regulate, helps them affect. Again, you have to, as the coach or clinician, identify, is this a sleep quality problem? Is this a falling asleep problem? Is that because of physical pain? Is it because of the emotional anxiety, dread, stress around going to sleep? Are they waking up despite sleeping really tired and fatigued? That would point to sleep quality, right? Or like Dan touched on earlier, an underlying sleep disorder like apnea is really common. People wake up often and they're like, I'm sleeping a bunch, but I'm not refreshed, right? And so that's how you can start to kind of tackle somebody's sleep-wake cycle just from a rhythm perspective. Then you would dip into circadian rhythm, right? Look at somebody's not only behaviors around bedtime, but the stuff they're doing all day that makes it either a lot easier or a lot harder to fall asleep at night. If someone's taking naps all the time, late in the day for a long time, good luck falling asleep when you want to at night, because you essentially think of it, the analogy I use is like a rice cooker or a crock pot. It's like, right, the steam is building, it's in there. And then when you open it, it all escapes. And that's what you want your body to kind of be able to do when you go to sleep at night, instead of it already released the steam, so you're not tired. Being sedentary also makes this hard, right? It's easier to fall asleep when you expend more energy. So there's a myriad of reasons why falling asleep and then sleep quality and someone's sleep cycle, as you start to dread and get more and more frustrated by that process, gets more and more out of whack. And then it starts to dramatically affect somebody's energy, obviously, right? Somebody's mood. And so these things can, they're interconnected, all of these different buckets. And what we want to do is see what's the combination of easiest, in a way, like most accessible and doable for the patient, as well as most impactful. So if you're really struggling with sleep, don't start with someone's nutrition. Like, start with their sleep and then layer in other things that are possibly affecting it. Are they eating late at night? It's not that nutrition can't be a part of why they're struggling to fall asleep. If it's a digestive thing, then it is. It's raising their core temperature at night, possibly. Another reason why it can then be hard to get quality sleep. So you want to investigate why, and then link, the appropriate intervention, which for us, we start with conservative and then move through medications to more interventive treatments. But for sleep, you don't need a block, right? You need a wind down routine. So Dan can't help you. Dan can't help you very much with your sleep, but he can't do a good job with what he needs to do if your sleep is so bad that you're, amplified to a 20 out of 10. So that's kind of an example of, how would we tackle somebody's sleep?
Yeah. So from a second line perspective, what I would then look at is, we're addressing the patient's sleep behaviors, and then what the patient's coming then to present it with, what they've done, their two primary presentations at this point is pain and sleep disturbance. So what am I going to do? Like, I'm going to look for a medication that will help me with pain and helping their sleep disturbance. And so in that setting, I'd start with something like amitriptyline. I wouldn't jump into the sedatives, like jumping into zopiclone or something along those lines that are purely sleepers. But what we want is something that will then address both the pain and the sleep disturbance. And taking that
kill
sort
two
of
birds
approach,
with one stone if you can, right, Dan?
Yeah, you're trying to kill two birds with one stone.
Do you do this, just a quick side note, also with antidepressant and pain? If someone's primary symptom, especially, right, is depression and it's a nerve pain situation?
Yeah, so you can go down that track. So if someone presents with neuropathic pain and depression, I'm going to go for a medication such as duloxetine.
Because it's like a version of the dial, most impactful.
Yeah, so it's probably going to be the most impactful medication for addressing the mood disturbance. And so in that setting, the mood disturbance in the form of depression or anxiety, it's going to be amplifying the pain. So if I've got something that has been shown to decrease neuropathic pain of its own accord, regardless of its effects on anxiety and depression, and I can knock off some anxiety and depression, great. I'm going to go with I'm going to go with that drug, and that's duloxetine is sort of the main one I would start with there. So this patient has also got orthostatic intolerance. So they stand up, they get lightheaded and dizzy after they stand for a period of time. So what conservative measures would you look to implement with that?
For conservative measures, the easiest three things are compression garments people can start with. The other low-hanging fruit in this instance is drinking enough water. You're going to want to get at least 3 liters a day if you're struggling with this type of thing. And then from a salt intake perspective, up to 10 grams a day is kind of the recommended amount to keep consistent to better manage this. Other than that, change positions, avoid the ones that are uncomfortable for a long time, like for me, sitting and standing are in that bucket. That's not rocket science. And then try as best as you can to progress exercise and expose yourself in ways that feel safe to do a little more so that you build some tolerance and don't lose as much capacity from a guarding perspective.
Yeah, look, I've got a bunch of patients that once they can get themselves doing some regular exercise, it actually controls their orthostatic intolerance quite well, actually.
Yeah. I think the weakness and the atrophy, and then also just not having confidence and being able to build some of that back and seeing that, your body doesn't always respond in that way. And in fact, when you're stronger, you get less of that. Yes, then it helps a lot to be more consistent.
Yeah, and then from my perspective, if they're not responding to like the conservative options, what am I going to do? Well, that's actually where I'm going to involve one of my cardiologist mates, and I'm going to send them off, and they're going to go through some appropriate testing. They may do some tilt table testing. They may then look for what are the potential underlying causes of their POTS. I will be thinking along those lines at any rate. Interestingly, the association of CSF leaks with POTS is 40% of patients with POTS have CSF leaks.
Yeah.
Like the number's massive. So like thinking along those lines and starting to investigate those sort of things is what I'm also going to be thinking. From a medication perspective, my cardiologist friends will be starting to think about metadrine, fludrocortisone. They may look at using beta blockers if the tachycardia or the palpitations are the main issue. What you can do is you can slow the patient's heart rate so it doesn't go up very high. It takes away that uncomfortable symptom. And particularly for patients with POTS where they don't have a low blood pressure, they've just got a high
It's
heart
the
rate.
high heart rate on standing.
Yeah,
And it's
beta blockers are completely important and appropriate in that environment. And then, longer term, third line type management, you're then looking at, I have one or two patients that are on, intermittent fluid infusions for rescue type treatment. So, but the important part out of this is if you don't ask the patient when they walk through the door to start with, because the presentation is so confusing, you don't then know that there's actually multiple pathways that you can run down to actually help these patients.
Yeah.
And it's not you're too complicated, this doesn't make sense, you're crazy, it's all in your head, get out. It's not. It's just categorize their symptoms. Once again, we'll just categorize them for us. So it's sensory hypersensitivity, sleep disturbance, fatigue, brain fog, mood disturbance, and dysautonomias. Categorize it into that. And once you can see the categories, you can then link them to appropriate, first line, second line, third line treatment.
Yeah.
That's
the
how we
beauty of
manage
it.
central sensitization.
Yeah, because it allows you to get all the weird stuff away, put it aside, and then you can actually address each bucket. So this has been a labor of love to develop and think through and sort through. And it has gone from such an overwhelming, large, bucket of concepts to something that now is actually relatively simple, I think, to be able to, if you can ask the right questions. And like Dan at this point just has a, check, check, check when someone's giving him their history because he's asking them the right questions. It's not, tell me, patient, how have you been the last 10 years of all of this? It's, that's a hard story to pull apart. And I think what's really common when you go through the stuff that I've lived with a lot of these diagnoses and other people is that you feel that you are terminally unique and that nobody else experiences and deals with the crazy, bizarre set of stuff that you are dealing with. And actually, there's a lot of other weird stories and other people that match these sort of patterns. And that's what I was seeing over and over again in the people I work with too. And just in the CRPS context, it gets so muddled and it's even harder in a sense to pull out some of this, but that was the pattern that I saw over and over and over again, especially in the EDS bucket as well, is these 6 dominant presentations. And if somebody has 1 or 2, it's a lot more manageable than when somebody has 6. I have multiple patients who have all of them. And it's been for a long time that they have all of them. That's like a raging forest fire. So the sooner you can tease these out and then go through 1 through 3, the quicker that you can shrink this down, because the challenge with sensitization as well is that it goes from proportional to disproportional, focal to spread, intermittent to constant. And there's no rhyme or reason anymore to what makes it better and what makes it worse. And so the sooner you can tease this out and also explain it to the patient, the better it feels as a patient understanding, oh, there aren't 27 things wrong with me. There's 3 bad things or things that are not well managed. That's such a less, overwhelming negative sort of sense of self that then the patient can also have too, instead of feeling like they're unfixable or, too complex to figure out. So it's been really cool to work through this with Dan. And I honestly can't think of any other physician who would have spent the time and the energy that it took with me talking through this and sorting through all of this. Cause, it's been a really special process, and I appreciate it, immensely, because this is a huge piece of why I suffered so much. People with CRPS suffer so much. It's actually not because of the CRPS. It's because of this piece that amplifies the hell out of an already very difficult situation. But if you can get rid of all of this, then what you're left with is so much better, and getting people from an 8 to a 5. That's the difference between someone deciding not, right, to carry on eventually versus like, oh, this life is still worth living. And so central sensitization, I struggle to understand why it's kind of like a castaway, not very much or well talked about aspect of chronic pain, when it is such a big deal for so many patients who present in this kind of complex, shoulder shrugging, bucket of stuff. It's tremendously impactful. So being able to systematically go through it gives clinicians a lot more power, and most importantly, patients a lot more power as well. Is there anything you still want to add, Dan, to?
Look, I think we have an entire podcast series that we could add to this. And I think that, and that's what we will do, because I think that there's some simple things that you can start to pull out. You can look at, interestingly, you look at the sweating data. So you look at all the data on hyperhidrosis and what are the treatment options for treating profuse sweating. You know what? They're all there. They are all in the literature. It's all relatively well defined. And all you got to do is you got to identify it, and then you got to use those treatment options that are already well defined and already there. The other thing that we've got to do, and we haven't touched on this yet, and we will in another podcast, is how do you appropriately investigate this? So the way
before treatment,
the way patients present to us, and the way patients present to us is with disproportionate pain. And it's disproportionate pain in association with sensory hypersensitivity, sleep disturbance, fatigue, and brain fog. That's the thing that defines nociplastic pain. However, patients will also present with things like fibromyalgia. They'll present with chronic fatigue syndrome. Patients will also present with other symptoms of central sensitization. So they may present with post-exertional malaise. So they end up having chronic fatigue syndrome. They also present with POTS, so they're tachycardic when they stand up. Each one of the organizations around the world that have been peak organizations, that they've defined how to investigate that. What are all the comorbid diseases? What are the appropriate ways to go around investigating somebody who presents to you with, in this way, extreme amounts of tachycardia, extreme amounts of thing. Like within the pain world at the moment, when somebody presents with nociplastic pain, the current approach is, well, that's a misinterpretation of a signal, and there's no ongoing investigation, where what I think we need to be doing is looking at more like this is a presentation of central sensitization. And just like with chronic fatigue syndrome, you need to go and look for all the differential diagnoses. You need to look for the comorbid diseases. You need to treat them. But there's so many of them, you need a structured way to go about that. And we'll go through what we've sort of pulled together now after 6 months of talking about how might be a reasonable way to investigate somebody that presents with nociplastic pain, but what's the underlying cause? Maybe that underlying cause is a persistent injury. Maybe it's persistent peripheral sensitization, which we'll talk about more at a later podcast. But also, maybe they've just got undiagnosed diabetes. Maybe they've got borderline renal failure. Maybe they've got, undiagnosed Sjogren's syndrome. Maybe they've got undiagnosed rheumatoid arthritis. And so we're not in a position where we shouldn't be in a position where we see somebody, we diagnose them with nociplastic pain / central sensitization, and see you later, get out. No, it is, we've got this. We now need to go and look for the comorbid diseases and investigate you appropriately. And then we'll go on and treat as appropriate. So, but we will get to that in many more podcasts at a later date. Central sensitization is also the way we describe it from a pain perspective, okay? But realistically what it is, it's central nervous system dysfunction. And so you look at other disease processes. So you look at renal failure. Renal failure presents with sleep disturbance, fatigue, brain fog, but it also has all the renal associated symptoms. So it has, peripheral edema, decreased urinary output, hypertension, electrolyte imbalances. And so a lot of other diseases have this overlapping set of presentations in the form of what we define as central sensitization. But you know what? It's probably better spoken about more like central nervous system dysfunction. But
Right.
that's a very long set of words. So it's probably never going to happen that way. But that's what it is.
Yeah. And we'll go from, obviously we're talking about this stuff to begin with in the context of pain and chronic pain, but this does apply to a lot more outside of that. And I think that will become apparent as you start to look at central sensitization as the same disease process in multiple or different parts of the nervous system. And then you obviously would get different primary symptoms depending on whatever piece it's mostly impacting. So having better definitions around that, allows us to investigate it better, allows us to treat it better, and allows us to empower both clinician and patient in a more collaborative problem-solving endeavor than good luck, you have central sensitization, which doesn't bode very well because and we talked about this too, and we'll talk about this as well in many episodes, but we look at pain as, this is one of a different mentor of mine's favorite quotes of his, that pain is a request for change. And if you look at pain and the output of symptoms as a legitimate, alarm signal rather than a misinterpretation, it makes sense why these symptoms escalate and escalate and escalate and escalate the longer that they're not addressed. And it's not that the patient got crazier over 5 years. It's that your body's screaming 5 years more at you. And there actually are a lot of things that we can do to address these things, which is really exciting. So I think that brings us to the end of this episode on sensitization. There will be many more because the podcast in disguise is a bit about sensitization, but we're looking forward to breaking that down further. And we will see you on the next episode of It's Not in Your Head. Thank you.
Right. See you later. Thanks for listening. Clearly, this is a podcast. It's for informational purposes. It's not a consult, medical advice, or the practice of medicine, and it doesn't form a therapeutic relationship. If you feel the information might be useful for your situation, before applying it to yourself or others, you should speak with your doctor or your treating clinician. Do not delay in seeking a diagnosis or treatment, and applying the information is at the listener's own risk.